So dear colleagues, thank you for coming so early and not missing this interesting lecture of Dr. Gladilin from Moscow, Russian Federation. Dr. Gladilin is an orthodontist and had his dental and orthodontic training at the University of Tver, Russia, and also had his PhD education in this site. So we are very happy to have you here, and we're looking forward to hearing your lecture. We will always tell the speakers 1 minute before the time is over that they should stop 1 minute later, so don't be irritated. And the title of this lecture is Advantages of Interactive Self-Ligation in Lingual Practice. Dr. Gladilin, please.
To participate in that congress, and thank you in advance for it. In an everyday practice of every clinician, after getting a certain high-level standard in treatment of lingual cases, an idea to increase both effectiveness and efficiency of lingual practice extremely often comes to mind. Each new tested appliance before introduction into active practice is definitely supposed to meet a series of requirements, among which the most crucial I consider to be the following. The first one is the patient comfort, simply handling for a doctor, total control over the tooth during the movement, and which is very important, the minimal chair time required to finish the case. Since it is no longer a secret that in buccal orthodontic self-ligation can greatly reduce the number of unnecessary visits and make necessary visits shorter in time, I tried to prove to myself the advantages of lingual self-ligation with the help of Lingual Innovation L system from GC. The flexible basis of this bracket makes the whole laboratory process much easier, and the resin pad much thinner than it was before with conventional brackets. An amazing ability of these brackets to be located closer to the center of resistance of the tooth, together with perfectly working latch which keeps the wire safely within the slot, gives the clinician 100% control over the tooth movement. I guess we shouldn't overburden ourselves with the use of different types of arch wires. For example, I'm 100% confident that almost every clinical case can be easily finished with the help of only 4 types of arch wires, and those are the arch wires which I routinely and daily use in my practice. The first one is 01290 Allen spool, which I cut off to the desired length and place it. This is the first one. The second is Thermoactive 1717 from G&H. We can choose it from any other company. The third one is 1725, and the last one is not a stainless steel and not PTMA, but a Calvaloy from GC, which is the same as Blue Angeloy from Rocky Mountain. I use it either in 16/20,000 inch dimensions for non-extractional cases, or for extractional with minimal anterior retraction, and definitely for detailing. And in cases of extractional, when the extreme and proper anterior torque control is extremely required. And here she is with midline centered and class 1 relation bicuspid and cuspid area. The smile before and after with the overall chair time of 120 minutes. If we try to calculate how much time is needed in order to finish the non-extractional, simple, regular case, with innovation L, it would be clear for us all to understand that 1.6 hours is the optimistic course of events if we try to finish it. Among those minutes and hours, 30 minutes will be taken for direct bonding and first arch wire placement. The second arch wire will take about 10 minutes, third one, and third visit, 1725. Calvaloy 1622 with several offset bands made in it, 10 minutes. Then 1622 laterals and Mahler bands in that area, 10 minutes for them, and if needed, additional bands will also require about 10 minutes. 20 minutes or even more depending on how well and how much you prefer to talk to your patient. It may take a little more, but in an optimistic course of events, the overall chair time will be either 100 minutes or 120, or in the worst case of events, in worst case scenario, it may be 130 minutes.
Yes, please. Edgar.
Good morning, thank you. About the time you calculated for the treatments, you have chosen cases where none of the clips was broken during the... because it's true, it reduces dramatically the ligation treatment time, but once one clip is broken, I think it increases dramatically also the chair time. Thank you.
Well, before we start to discuss the possibility of clip or latch breaking, I have to say that in working with innovation, if a clinician starts to work with the second or the next arch wire a little later than he was supposed to do it before with conventional ligation. Or I must say, a little bit, be some time, a little delay, not to be in a hurry to change the archways. In this case, the risk of ledge breakage is minimal. If at a certain stage we get that complication, which to my consideration can be extremely rarely gotten, if we get it, there are wings for conventional ligation, so we can use it anytime we want. So if on the whole arch, one elastic ring will be put on several wings of one bracket, I think it will never be able to to increase dramatically the overall chair time. Answering the question about the calculation of the chair time. The method of calculation was extremely simple. My assistant was just putting out on a special chart how much time given and dedicated to each patient I saw with conventional and with self-gating appliances. Here you are. I hope it gave you the exhaustive explanation.
Thank you, and thank you, Edgar, for asking 2 questions. So thank you for your 2 answers.